step was, let's go back to the Board of Health Handbook, which I believe had not been revised since 2007, and let's put it in plain English, and let's arm our county attorneys with every citation we can come up with, and let's try to give people a better idea of the roles of the various people involved in this. Georgia follows what's called a hybrid system. We have a situation in which responsibility is shared by three principal actors. One of them is the Department of Public Health. This is a state agency downtown, and that's headed by Commissioner Brenda Fitzgerald, and it is staffed entirely by state employees. On the local level, Georgia has 159 county health departments. These are independent legal entities, and their employees work for the County Board of Health. They don't work for the state, and they do not work for the county per se. They work for the County Board of Health. And this is extremely confusing, and I've had attorneys just have fits over this issue because they say, wait a minute, these people are state employees. They participate in the state health benefit plan, and they are covered by the state insurance policy, and they're subject to, you know, the state retirement system and all of this, and they answer to a state employee, the district health director, but no, they are county employees. And in the middle of this system, we have a group of 18 people, 18 remarkable people, and these are our district health directors. And they have, in my opinion, the hardest job in state government, second possibly only to the governor. Extremely difficult job. Every one of these 18 persons is a medical doctor, is a practicing clinician, has experience and training in public health, which is a specialized branch of medicine. They have administrative skills. They have budgetary skills. They have to manage a lot of people, and some of them manage 12 health departments scattered over hundreds and hundreds of square miles. Some of them answer to 14 different boards of health and attend 4 meetings per year of each of those boards of health. You do the math, that's a lot of time on the road. And each of them is responsible for an army of physician's assistants and nurses who operate under written protocols and for whom they are legally responsible. There's often a pharmacy sitting in there too. They're responsible for the scripts that fly in and out of that pharmacy. This is an extraordinarily difficult job, and they are asked to do the impossible with not enough resources. The district health director is a state employee, works for Commissioner Fitzgerald just like I do. The difference is that before the district health director can assume her position, she has to be approved by each of the boards of health in her district. And if any one of those boards of health says, we don't like this person, we have to start all over again. And believe me, it is not easy, as you can imagine, finding people who have those qualifications. So you're going to hear me wax eloquent a lot about our district health directors. They are remarkable folks. Now, before we get into some of the nitty-gritty details of how this hybrid system works, let's talk about money. All right, this is another thing about public health that makes it an extraordinarily difficult field. The last agency I worked for had a $19 million budget, every dime of which came straight from the General Assembly, straight from the state treasury. And we spent it to run our department, and that was that. The Georgia Department of Public Health has a budget of nearly 2/3 of $1 billion, and it comes from dozens and dozens of different sources. We get a little bit less than $200 million a year from the state treasury, out of the state budget. We get about $500 million a year from the federal government in various little pots of money, each of which has strings attached to it. We have dozens and dozens and dozens of these pots of money. And we also have dozens and dozens and dozens of auditors who are ready to swoop in and make sure that we are following every do and don't that is associated with that money. We get a pot of money to do HIV testing. We got a pot of money to do emergency preparedness. We got a pot of money to do family planning under Title X. And woe unto us if a single dollar from those pots is used for any other purpose. So we have a small army of financial folks on the 15th floor at 2 Peachtree Street whose job is just to track this money as it comes in and it goes out. No other state agency has this problem. We also have a situation where we spend a lot of our budget, both state and federal, on private contractors. A lot of the money comes in one door and it goes right back out the other. We have a very large procurement section. We rely very heavily on the public sector to carry on the work of public health. So we've got contracts with CHOA, we've got contracts with the Georgia Hospital Association, we've got contracts with My Sister's Home in Savannah to make sure that HIV-infected folks are linked to available services in the community. We have hundreds and hundreds of contracts going out the door every year. And I got one poor lady with a brand new baby on the 10th floor. She has to read every one and approve it before it goes out. And then I have to look at it and approve it. This is a pretty unusual setup in state government. Now let's talk about your end of it. All right, what does this money mean for you? Every year, the Department of Public Health takes a big chunk of that state money and we parcel it out to the counties. This is called grant and aid. And we will usually take about half of the money that we get from the General Assembly and we will flow that out to your counties through grant and aid contracts. This is a contract with your county in which we give you money and we tell you that you got to provide certain services with it. These are your core, basic, plain vanilla, garden variety public health services. And as any district health director will tell you, Dr. Harvey, tell me if I'm wrong, we don't give you enough money to do all these things. No, Dr. Harvey says, no, you don't. And Commissioner Fitzgerald is doing everything she can to try to increase that pot. And she's had some success. So STD testing, screening kids for entering public schools, screening the vision, hearing, dental, nutrition, all of the services that we expect to find when we go to the public health department are largely funded by this grant and aid. Now, we also use this grant and aid contract to funnel to your counties some of those pots of monies we get from the feds. And with that money comes the strings and the possibility of being audited to make sure that you're following all the do's and don'ts. So you will be getting some of that Title X money to provide the family planning services in your county. And you'll be getting some of that money to help provide, to help set up emergency preparedness in your county in case you get hit by a tornado, in case you get hit by a terrorist act, in case the zombie apocalypse comes. We're helping to fund all of that. So understanding where the money comes from is a great way to start understanding some of the stresses and the restrictions and the opportunities that come with public health in your county and some of the responsibilities that fall on the shoulders of your district health director. Now, I want to talk a little bit about some of the specific roles of state versus district health director versus Board of Health versus county commission. Do we have any county commissioners here? Good, okay, because y'all have a role too. And not enough is really said about the role of the county commission. The public health department is not the boss of your health department, but it is sort of the boss of your health department. I'm just going to put it that way, sort of. That's my legal opinion. We're sort of the boss. The State Department of Public Health has certain responsibilities that are unique to the state, and y'all don't have to worry about them because we're taking care of them. We run the state public health labs. We've got two of them in operation. We've got one in South Georgia. We've got one on Claremont here. They're the ones that do the testing. And they not only do the testing for the public health system, but they do the testing for a lot of private doctors and a lot of private hospitals and a lot of private clinics because we do certain types of tests that nobody else does because you can't make any money doing them. Okay? If somebody in your county says, my dog is acting really strange, and they have to put the dog down and find out if it's got rabies, then that dog's head is going to be sent in a bucket to Claremont, and they're going to test it for rabies. We do a tremendous amount of HIV testing out of these public health labs. We have one program that we are especially proud of. Every newborn child in Georgia, every newborn child without exception, is tested for a roster of metabolic diseases within days of birth. And that report is given to the parents and to the pediatrician so that if you have one of these horrible, awful diseases, we will know as soon as possible and we can take corrective action. Every child, without exception, that is born in the state of Georgia, we don't care who your parents are, we don't care their citizenship status, we don't care how much money you got. We're very proud of this program. So we do that. Counties don't have to worry about that. We regulate ambulances and ambulance services and the people who ride on the trucks. We regulate EMTs. We license them and we take away their licenses on occasion. We provide the central organization and planning for the WIC program, Women, Infants, and Children. We manage the vendors in the program. We handle the money there. We handle epidemiological studies, which is that we track disease throughout Georgia. Some of you may not know this, but there is a list about this long of diseases that are called notifiable diseases, and we are constantly updating this list. When any doctor, any clinic, any hospital in Georgia finds somebody with one of these diseases, they report to us immediately, all of the details. I got a fella on the 16th floor with a few keystrokes. He could print me out a map of Georgia with a dot showing everybody in Georgia who has tuberculosis. He can print me out a map showing everybody in Georgia who's tested positive for HIV. As you can imagine, the responsibility of securing this database is tremendous. These are names and addresses, folks. We got them all. Why? Because this is the way that we get a real-time picture of what's going on with the health and people in Georgia so that we can make the right decisions. We don't make decisions based on what we think is the best or our ideology or anything like that. We are a data-driven organization. Show me the data, and then we'll talk about what's best to do. So we handle those kind of functions as well. We do some what I will call retail services, usually through contractors, but for the most part, the retail business of public health takes place in your public health department. That's where the client contact takes place. We don't have a lot of client contact at 2 Peachtree Street. It's the nurses and the medical assistants and the nutritionists and the dentists and the doctors who work in your local health department that have 99.9% of the retail delivery of public health services in the state of Georgia, your local health department. As I've said, in between these two structures is the district health director. The district health director is a state employee, but by law functions as the chief executive officer of your health department. He or she manages the people. He or she manages the clinical aspects of the program. There are many districts where we have multiple doctors. There are some districts where we only have one. So this person is responsible for overseeing the nurses and the PA in that district. A tremendous responsibility. Some of our district health directors, I believe all of them actually see patients. And they are your principal contact because they are, like I said, the statute actually says they're the CEO of your health department. And they handle the management decisions. The County Board of Health has a number of powers that are unique to it. Now, I have met some folks in the last 2 years, and I met a very, very smart lawyer who just got onto the County Board of Health, and he said, you know, the more I looked into it, the more I came to the conclusion I didn't have any power and I didn't have anything to do. Your district health director does everything. What am I here for? And I said, that's not true. All right? If you want to get your friend on the staff down there, no, that's not your responsibility. It's sort of like the school board. You know, we've always got somebody on the school board trying to get their buddy a job or something like that. No, 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 no. Y'all know you're supposed to stay out of that. But the County Board of Health fulfills a function which is absolutely critical and which nobody else can do. There are several of them, and I sort of outlined them in here, and I really want to emphasize these to you. Number one, the County Board of Health is the eyes and ears of the community. Now, the district health director is in charge of providing these services to your county. And good district health directors try to keep their finger on the pulse of the counties. What are the needs? Who are the people? Where do they live? What are their problems? What do they need help with? And this is different in every county. Obviously, Fulton County, Screven County, Troutland County, Walker County, you are not going to have the same populations, not going to have the same problems, not going to have the same challenges. So we count on the district health directors to do that. But a good Board of Health will come to the district health director with its collective experience and knowledge and say, you know what, our county really needs more help in family planning. Or we see a need out there. We're starting to hear of lots and lots of, for example, in one county, we're starting to get more and more immigrants in here. They don't speak English. They're not getting tuberculosis testing. We're starting to get a cluster of tuberculosis in there. We're starting to hear this. They can bring this information, they can bring this guidance, and they are expected to provide policy guidance to the district health director. And the district health director then turns that into action and implements it. So that's one of the things that we really count on, is y'all need to be the eyes and ears of the community. You need to help the district health director understand the needs of your community, and those needs change from year to year. Another thing that you can do, and to me, this may be the most important thing that the Board of Health does, this is in my personal opinion, and that is the Board of Health is the pipeline to the county commission, and that's where all the money is. If you, as a Board of Health, decide that the county grant and aid funds that come from the state are sufficient to meet the public health needs of your county, and that they are already providing all of the services that the people in your county need, then you are free to report back to the county commission that we don't need any additional county funds, we're doing fine. You know, the district health director will tell you that as a condition of getting some of these federal funds, you've got to match them, so there'll be a match, and everybody does the match. Who would want to give up money? So you are free to do that if you want to, but I don't know of a single county in Georgia that does that. And so here's what the Board of Health does. It communicates with the district health director. It puts its finger on the needs of the community, what services our people need. And to do that, you got to know who your people are, including the ones that live way off there in the hinterlands that you might not see at church. And working with the district health director, you say, in addition to what the state pays for and provides and what you do with that money, we need some more help for our people. So let's figure out what sort of help we need and how many people it takes and how much money it costs. And then we are going to make a recommendation to our county commission that they provide county funds equal to meet that need and supplement the state budget of our county health department to enable our district health director to get the people and the resources that he or she needs to meet that need. To my knowledge, every county in the state does that, some more than others. But for my money, this is the most important thing that you will do. Every year, you will make a recommendation to the county commission. We recommend that to serve the people of our county, we provide X dollars in county funds to supplement the county health department budget, and not just give them a pot of money. We'll have a plan from our district health director. This is what we're going to do with that money. These are the services that we're going to provide. These are the people we're going to provide it to. These are the metrics that we will use to make sure the money is spent wisely and that we get the result that we want. And to me, that is the most valuable thing you folks can do for your counties every year, is to have that conversation with the district health director, to put that price tag on, and then to sell it to your county commission to make sure they understand, yes, nobody likes to be taxed. Nobody likes to spend tax money. But we can get some bang for our buck and make this county a better place if we can just have this much money supplement our county. And that is the unique role of the Board of Health.